Good evening from Montreal. I am Kirsten Johnson, and I practice emergency medicine at McGill, and I am also the incoming president for the Canadian Association of Emergency Physicians. So as you can imagine, there's a tremendous amount of organizing and logistics that have to occur to bring you our weekly town hall. With the chaos of this extraordinary time, in scheduling this week's broadcast on Airway and critical care, we completely missed that it coincided with the first evening of Passover, an incredibly meaningful and important event for our Jewish colleagues. We sincerely apologize for this oversight, and to the members of the emergency medicine community who are celebrating, Chag Sameach. The recording of this town hall will be made available for everyone to view tomorrow. For those of you who are unable to attend tonight and/or who have questions for the speakers after viewing the recording, please direct them to Christina Bova at cbova@cape.ca, and she'll follow up with you. It's a strong membership that allows CAEP to provide you with a COVID-19 town hall, a robust information center, and all of the advocacy efforts to date. So thank you to all of those who have joined or renewed this year. But it is crucial now, more than ever, to strengthen the voice of emergency medicine by becoming a CAEP member. If you are not one already, you can join or renew at cape.ca/membership. And if you need assistance, you can contact Christina Bova directly. Her information is on the membership page. As the COVID pandemic progresses, we are on week 4 here in Montreal, we are learning more about the clinical course and management of COVID patients. There has certainly been a lot of discussion around early intubation of these patients, and perhaps this is not the way to go, and that we should allow for permissive hypoxia and base our clinical judgment off work of breathing. In fact, the role of non-invasive ventilation instead of intubation is now being more hotly discussed. And so I think we're really lucky today to have 2 experts to address some of this thinking and answer your questions on the different approaches to managing airway and ventilation depending on the type of COVID patient you might have. Dr. George Povich is a full-time professor of emergency medicine at Dalhousie University. He works clinically as an emergency physician and trauma team leader at the Queen Elizabeth II Health Sciences Centre in Halifax. He is the medical director of Life Flight, the provincial critical care transport program, and he's an award-winning educator who co-developed the internationally recognized airway education program that we know as AIM. Dr. Sarah Gray, who was once named Toronto's best ER doctor, works in Toronto at St. Michael's Hospital. She's an associate professor in the Faculty of Medicine at the University of Toronto. She's cross-trained in emergency medicine and critical care, and she divides her work between emergency medicine, critical care, wellness programs, public speaking, and professional coaching. She is the past chair of C4, the CAEP Critical Care Committee, which is Canada's national group of combined EM ICU people. So we'll start the town hall with Dr. Gray, and then Dr. Povich will jump in, and Dr. Gray will wrap it up. After the presentations, we'll open it up to questions. So please do submit your questions as we go on the live stream chat or text directly to the number on your screen. Patrick Mooney, our medical student, who has been doing so much work behind the scenes, will do his best to collect them all and then send them on my way so I can put Sarah and George on the hot seat. So without further ado, I'll hand it over to Sarah and we'll get started.
Okay, fantastic. I don't know how much people heard from the original intro, perhaps nothing, but I really just wanted to start with the idea that we're learning really rapidly about COVID. The information cycle is very fast, but at the moment, most of the recommendations we can make are based on expert opinion and based on anecdote. So please be mindful that there is not hard data for much of our practice right now, and that this is normal in a pandemic. We need to stay flexible, and we need to keep our practice reasonable. Your practice depends on your resources, it depends on your location and where you are in the pandemic. So we may not all be doing the same thing at the same time across the country, and that is okay. We just need to, on the F side, Emerge docs are fabulous at flexibility. So this really plays to our strengths. We just need to hang on to that. And so I'm going to start with talking about who we intubate and when. And this is our bread and butter in emergency medicine. We know who to intubate generally. We all know that list of indications. So if you're having failure to oxygenate, failure to ventilate, there's airway obstruction, or you anticipate that the patient's going to deteriorate and need an airway, Those are the standard things we use. And so when COVID started, people were saying, wow, they deteriorate really fast. Once they're on just a couple liters of nasal prongs, maybe 4 liters, we need to intubate them right away. I heard a bunch of different numbers used at different centers. But what we have learned is that we can be a little bit more nuanced than that because we understand COVID a little bit better. So I want to tell you about the different presentations of COVID, and we can talk about when to intubate them. And I really think of them as 3 big groups. The first group is the really mild ones. These are the people who just come to your emergency department with an upper respiratory tract infection. They are not very sick. They don't need oxygen. You just send them home. The second group are the group of happy hypoxics, or the silent hypoxic group. We're going to talk about this more in a minute because this, I think, is a new phenomena for us that we don't really see in other disease states. So first is the mild disease, second is the happy hypoxics, third are the people who are just crashing. In general, they'll have hypotension, they may have multi-organ failure, they're certainly hypoxic. For those people, you just intubate right away, and there doesn't need to be a lot of decision-making around the intubation. So the happy hypoxics, that middle group, are different for us because we haven't seen this in a different disease state. And it's actually a fascinating part of COVID. There's this group of people who come in, they're COVID positive, and they are extraordinarily hypoxic. They will have SATs in the 80s or the 70s or the 60s. I've seen some Twitter videos of people with a 45, but they are still mentating. They have a decent blood pressure. They have a normal heart rate or close to normal heart rate. And this is a tricky group for us because we haven't seen this previously. They will sometimes have a lot of tachypnea. They tend to do rapid shallow breathing. And so respiratory rate is not as useful as an indicator for us in terms of whether or not to intubate. They tend to do this rapid shallow breathing because it stops them from coughing. Deep breaths will tend to put them into coughing fits. And in the first little while of COVID, we intubated all of these people right up front. And it's not clear anymore that that's the right approach. And I want to be clear here that the approach you use may vary depending on the resources you have. If you have tons of ventilators and tons of ICU capacity right now, then intubating them may be the appropriate step. If you are in surge or you have limited capacity, then you might want to explore some of the other options. So let's talk through what else is available for you. So number 1, you just start by putting them on oxygen, whether it's your nasal prongs. You can use a non-rebreather with a surgical mask over top to reduce the droplet spread. At my place, we're using what we call high ox masks or Povich masks. This is like a non-rebreather, but it's got a filter on each side. So it's got little white filters on each side over those holes. And you can titrate that oxygen to see if you can get a SAT of greater than 90%. In general, we're shooting for a SAT of 92 to 96. That's perfect. You don't need higher than that. You don't need to keep people at 99 or 100% because you can actually make them hyperoxic, which can be damaging for their lungs. So getting a SAT in the mid-90s is fine. And then you watch them for signs of deterioration. And the important signs you're looking for, number 1, is their mental status. This is crucial. If they're getting uptunded, they're confused, they're dropping their LOC, that is a clear indication to intubate these hypoxic patients. But many of them are maintaining their mental status perfectly. They're texting, they're talking to you. So the second important piece that we look for in terms of are they deteriorating, we're looking for signs of fatigue. So the easiest way to assess fatigue is just to ask them, because they're awake. You could just say, are you feeling tired? Are you feeling short of breath? Because many of them can tell you when they start to feel that way. If you're not able to have a good conversation with them, you can look at their work of breathing. Do you see all their accessory muscles going? Are they paradoxing? Are they sweating? Are they starting to look agitated? Those are all signs of deterioration. And last but not least, you can start looking at lab markers like a venous blood gas. So is their PCO2 rising or is their pH going down? In general, these hypoxic patients, because of their quick breathing rate, they're going to have a low PCO2, often somewhere in the 20s. When you see that number start to rise, that is a sign of fatigue. It's a sign that they're no longer able to keep up with their work of breathing, and that can be one of your indications for intubation. You want to remember for these patients that their end tidal CO2 is not as accurate as doing a venous blood gas or an arterial blood gas. And so I know we don't like to do gases unless we have to, but end tidal CO2s in these patients are less accurate. These patients have a lot of VQ mismatch. They've got significant dead space. And so we're really seeing less accuracy out of our end tidal than you would in a different patient. So you have them on oxygen. You're watching for signs of fatigue. The other thing we're trying for these patients who are hypoxic but still holding their own is you can have them self-prone. And it seems to work really beautifully. And what this is you just have them move around. So they can lie on their stomach for an hour, then they can lie on their right side for an hour, then they can lie on their left side for an hour. They can move wherever is comfortable for them, but moving them around actually helps them improve their VQ matching. So this can be a really important thing for people who are hypoxic, even to have them lie on their side, whichever side is most comfortable for them. You don't need to push them to stay in a position that is uncomfortable for them, but having them move around seems to be acutely helpful. And I've had a number of people on nasal prongs with a borderline SAT get them to lie on their stomach for an hour and their SAT dramatically improves. So it's worth considering whether you can move them around or get them up to a chair, but that mobility piece is important. And it can really reduce how many of these people we need to intubate. And you can also just use it as a concept for the people who I'm planning on intubating, and I'm outside the room getting the drugs or getting my gear on, have them lie on their side during that time to help them pre-oxygenate before you get in there to do your RSI. So you have them on oxygen, you're having them self-prone if possible. It's much easier to have somebody on nasal prong self-prone than it is to do it on an intubated patient. The last thing you consider for these happy hypoxics is many of them are having chest pain. There really seems to be almost like a pleurisy, like an inflammatory chest pain from COVID that limits people taking a deep breath. So they're doing this rapid shallow breathing, but if you give them some pain control, they can breathe more deeply and improve their oxygenation. Now, you obviously don't want to give them anything that's reducing their respiratory drive, so I would avoid the narcotics here, but you could consider a one-time dose of ketorolac or an NSAID. You could consider some acetaminophen. I have seen people using really tiny low-dose ketamine as a pain control option. I have heard some people are putting people on PCA. That has some risks, obviously, with respiratory drive, but considering giving them pain meds to help them take a deeper breath can really help you in that middle group. If your patient is starting to deteriorate, you will see it happen. This is what we are good at. And I know people were quite scared in the beginning that these people all decompensate immediately. It's not the case. Some of them do just fine on a prolonged stretch with just oxygen. So it's worth considering, especially if you are in surge or you're running out of resources. And so that's what I wanted to start with, just about thinking about who to intubate. Kirsten, before we throw to George, I don't know if there are any questions that have come through on the chat that you want me to address.
Sure. I hope that there's no feedback now. Everybody's okay with this. So we do have a couple of questions. First of all, from a rural doctor who is practicing where there is no glide scope. And so it's kind of more of a technical question, but is an LMA okay to use when there is no glide scope for as a definitive airway management tool?
Absolutely. And I'm going to let George answer most of the questions about the devices we're using. But certainly if I didn't have a GlideScope or a video laryngoscopy device, then I do think LMA is a reasonable option. George, do you want to weigh in on that?
Yeah, so complex question. We assume that we often have all the gear, and many places don't. So we have to be realistic. It's not really about the device per se. I will address that, but it's about, they have to be able to tolerate what you're putting in there, right? So you'd be doing this in the context of a rapid sequence intubation, or you'd be doing it perhaps in an arrest scenario. So it really doesn't serve as an alternative for an endotracheal tube delivered by VL. But if that's all you have, that's all you have. I think one of the big messages is going to be here is that, as Sarah has said, would they be okay with just some simple measures in terms of oxygenation until they were able to get to, or help was able to get to you, or you were able to get to help, so that the procedure that needs to be done can be done. I'll talk about that more.
Perfect. There's just one other question, and that was an update on non-invasive ventilation versus high-flow nasal cannulation versus intubation. And so, Sarah, you did touch on that. I guess, if there's any updates on the use of Cpap and putting a mask on a patient or anything like that, so that we don't have to go to intubation with the happy hypoxics, maybe you could just touch on that before we move on to George.
Sure. This is an area that's continually changing. So I think in the beginning of COVID, we heard, don't use non-invasive, don't use high-flow nasal cannula. Both have a risk of aerosolizing particles. And so I think if you have lots of capacity and you can avoid using those things, fine. As places are starting to run out of capacity, run out of ventilators, run out of ICU beds, we do see hugely increased numbers of use of non-invasive, of Cpap, of high-flow nasal cannula. So I think it's worth understanding how to use those. If you do need to use a device that is aerosol generating, then you're ideally doing that in a negative pressure room. You're doing it with airborne PPE on. You're minimizing the time that you're in the room and minimizing the exposure of personnel in there. And even now, I think we're seeing variability across the country in what different jurisdictions are recommending. So at my place, which is just one hospital, we are not using non-invasive, but we are using high-flow nasal cannula in negative pressure rooms. But I also know of places that are doing Cpap or non-invasive in negative pressure rooms, and I know places that aren't using either. So I want to go back to one of my original points, is that you want to keep your practice as safe as possible, and you want to keep it reasonable. Keep it in line with what people are doing in your jurisdiction, or come up with a hospital guidance or provincial guidance of what you're going to use, and keep your practice reasonable. That's all anybody can ask of you. These are extraordinary times, and you do whatever you can with what you have.
Thank you. Just a couple more quick questions, if you don't mind. One is, have we established if there's a change in hemoglobin oxygen binding with COVID-19 to explain the low O2 sat in these happy hypoxic patients? And what is the critical window for them to crash? Like, can they crash after 8 to 10 days?
Yeah, so the first question, initially when we were seeing these happy hypoxics, people wondered if there was a hemoglobinopathy or some other problem with hemoglobin carrying capacity. That does not seem to be the case. They actually seem to be truly that hypoxic. When we're doing arterial blood gases, their PaO2s match the SAT. So we can't necessarily explain that physiology yet. There are a number of theories, and none of them, to my knowledge, have been proven yet. But it looks like a real effect, not a hemoglobinopathy. And Kirsten, forgive me, I forgot your second question.
So what is the critical window for them to crash? Can these happy hypoxic patients crash after 8 to 10 days?
Right. So we are seeing, thanks, Kirsten, we are seeing a number of people crash at about the 10-day mark. I do see that and have heard that anecdotally, but not all of them do. I've also had a happy hypoxic in my unit for days. She stayed on her high flow nasal cannula for days and then turned around and never required intubation. So it's like real life. There is not a specific time when they're all going to crash. Some of them are going to crash early. Many do crash around that 8 to 10 day mark, but some don't crash at all. So we need to keep harnessing our normal skill set. We are really good at telling when people are sick and when they're not sick. And we need to keep using that clinical judgment that we have such expertise in.
And how about their CO2 levels? If they're maintaining the saturation, should they be fine, or will they still have? Should we still be worrying about CO2?
So if they're maintaining their oxygenation, that's the first thing I like to see. But then I'm still checking their CO2 because I use that as a marker of when they're tiring out. So if they start to have a PCO2 rise, or their pH is dropping, they're becoming acidotic, those are markers for me that they're getting tired and I need to change my strategy or increase my flow or ask them to self-prone, but I need to reassess them because that's a marker that they're getting worse.
Great. So we do have more questions coming in, but maybe we'll move it on to George and then we can open it up and I'll address some of these at the end and both of you can jump in because there are, again, some of them around Airway and so forth. So George, maybe we'll hand it over to you and then we will keep the rest for the end.
Sure. So I wanted to start by, I've never been to a town hall and so I didn't know how to dress. So I want everybody to see I've got a nice snazzy tie for the occasion and just for you. So I've got a series of slides so you don't have to look at my pasty face. And I'm going to take you through some material here. So I'm going to just share my screen and is this right? Yep. And start sharing. And what?
And find your stuff.
Okay. All right. So can you guys see this? Can you hear me?
Yeah.
Oh, I'm. Okay. Exit here.
Yeah.
Okay. And then here, and I'm going to go with that. How are we doing? Okay. All right. So just some happy pictures. It's nice to see happy pictures around this time. You guys probably heard me talk about how it's time to make the awake intubation approach a reality in the emergency department. And obviously, this is a talk that's going to be put aside for a long time. The talk that I did before was Awake Intubation Masterclass, and it was really modeled after a hero of mine. This is Aaron Franklin, who's a Texan barbecue, and many of you have come to know that I love barbecue and I love Texas brisket. So this picture was when I did TO, and it was about bringing a brisket to the resuscitation room. And I'm clearly not going to talk about awake intubation. I'm going to talk about something different. So this is COVID-19 intubation class 3. And what I mean by class 3 is what has already been brought up by Sarah, is that's all the evidence that's out there. It's poor quality evidence. It's expert opinion. It's consensus. And a lot of this has been learning from others in hot zones. I've been in pretty well daily contact with colleagues in New York, and what they're experiencing is crazy. But we have the opportunity to learn from them, and those anecdotes are going to be valuable lessons for us. But remember, if you'd see me give a awake intubation talk, it's still all the same thing. About the right occasion, the right preparation, the right place, the right approach, the right gear, and the right execution. So the right occasion. It's a pneumonia. We're calling it COVID pneumonia, but it's a pneumonia. It's the right preparation, right? You're gonna manage this patient's airway. You got to manage your team. You got to manage yourselves as individuals, and you got to take care of the patient. And there's a bit of a paradigm shift in which we're prioritizing the patient, the provider over the patient. It's about the right place. In other words, we're going to do these procedures in a designated areas that'll tolerate aerosol generating procedures. We're going to do the right approach, which is a physiologic sensitive RSI. And we're going to do the right gear, and we're going to practice using that right gear. So we're going to be using video laryngoscopy as our approach, and we're going to be doing that wearing full PPE. And ultimately, it's the right execution. I'll talk about this a little bit more. So as you go to prepare these patients for doing this RSI, it's about using Cpap. It's about using what we call apneic Cpap, and ultimately getting the tube in the right place. So it sounds like a lot of things that are different, but if you think of the big picture, what we're doing is we've got a sick patient that has a pneumonia, and you're going to do an RSI, and you're going to use a video laryngoscope, and you're going to do it rapidly. And all the rest of this stuff, there's some nuances and stuff, but what people forget, we're doing the same thing, right? And that's got to be the message. This is a document that we will be sharing on our website later on, and this is our second iteration. So airway management guidelines for patients known or suspected COVID-19. And again, it was a shared document with emergency medicine, with anesthesiology, and with critical care. And it's actually being deployed province-wide. It was uploaded as of tonight, and we'll make that available for open access. And it does address a lot of the issues that Sarah have already talked about, right? We don't run in an intubate based on a number. Right? We don't do anything based on a number in emergency medicine. So we're recognizing from the experience of others that it might be appropriate to try alternative escalations in therapy. And those escalations in therapy might be humidified high flow oxygen, or they might be the use of Cpap in selected patients under close observation. I'm not going to talk any more about that, but I will say, because I think this is important, what I'm trying to speak about in the next half hour really is about 2 weeks worth of materials. And there's tons of materials on our website. We've completely repurposed it. We're not selling courses. We're just putting up open access materials. They're procedural videos, they're approach videos, and they're updated on a regular basis. The other thing I'm going to make a clear statement about, I'm not going to talk about PPE today, not to talk about it because it's not important, but it has been addressed, and it's so crucial. But again, as part of this, we're not going to address this. We're going to focus on intubation in the right patient, recognizing that we are all going to be donning the right equipment, the right PPE for this aerosol generating procedure. All right. So the principles are: the goal of airway management in COVID-19 patients, once the decision's been made to intubate, is perform it safely. Sounds pretty common, usual stuff we say. But what are we talking about from a safety point of view? Safe means rapidly securing the airway, but safe also means slowing down and prepare yourself, the team, and the patient. So we're used to seeing a patient in a room with SATs that are 60 or 40. And what do? Well, we don't slow down. What we've done historically is we've tried to get in there and do what we have to do and get that patient tubed. And if you take that attitude and you apply it to this patient, then your team is not going to be safe. So safe does mean slowing down, preparing yourself, the team, and the patient for this scenario. Again, Mike Laurie has said this, and apparently it's a mantra of the Naval SEALs: slow is smooth, and smooth is fast. And the issue comes up now is that we're managing these patients, but we're not managing them in the places where we're used to. So when you go into your resuscitation room, you know where your gear is, you know where to look left, look right, etc. Many places don't have negative pressure resuscitation rooms. So they're using negative pressure environments that they're not used to. And they have small ante rooms, but what you need to be able to do is you need to be able to do that procedure in that environment that you've never done it before. So requires a lot of practice, a lot of organizations to make these safe environments so you can perform the procedure safely. So I've been saying practice a lot, and I don't want to make this sort of a big educational talk, but this is important. We have to practice from a team perspective. We have to practice from an individual perspective, because these are halo events. These are high acuity, low opportunity events. And I know Petro and Chris Hicks are going to be happy that I'm putting up this slide. And this is where simulation comes into play. The irony is, to deal with halo events, the most effective intervention to do is that you have to actually overlearn it. So you have to do it more than what you would do normally to get that skill set. And so what that requires is that we have to spend the time to make that a reality. So what things do we have to do as an individual? We know all these things. We need to know how to don and doff, but you need to know how to do the stuff that you do routinely, such as difficult mask ventilation, difficult VL, placing a supraglottic airway, and doing a cricothyrotomy, all in PPE. Right? So you can do it on your own when you're just going in and managing this patient, but doing it with PPE, how does it affect, is your equipment fogging? How does it affect your peripheral vision? Is there glare with it? Are you comfortable in performing that procedure in that context? And from a team point of view, all the stuff that we know about, communications, PPE checks that you planned, you have a articulated plan, A, B, C, D. You understand the sequencing, right? So that's what's one of the things that is different. The RSI, it's not just a simple RSI. There's a lot of little pieces that you're going to adjust. And again, you have to do room-specific in situ sim. So when you look at this, it's like, wow, it's a really colorful, great checklist and a great algorithm, but it is useless unless you've spent the time with it. This has to be the purpose of having a checklist and having an algorithm is sharing your mental model, so that your RT in the room, so that your doc and your medic or your nurse, they're all looking at that and they're seeing the same thing. If you employ a checklist or a visual aid for the first time in a sick patient, it's going to be a hindrance. It's going to cause problems. So in order to make this a reality and effective, you have to practice in doing this. You've heard me say this before, concert violinists, special forces people, high performance athletes, they spend 90% of their time practicing, but only 5% of their time performing. And what do we do in medicine? We spend the majority of our time performing and little time practicing. And this is a call to change. COVID mandates that we practice more than what we are used to doing. Because here I'm doing video laryngoscopy. It's pretty straightforward, but I'm doing video laryngoscopy wearing PPE, and that affects the way I do that procedure. And so what comes to this is that we think of the difficult airway being around patient issues, right? Their anatomy, their physiology, their cooperation, and all that stuff. But what's the potential bigger danger is the environment, right? How comfortable are you in performing that procedure? How comfortable are you with using the equipment? What sort of support do you have immediately available to you? So it's these two things that are going to determine outcomes. It's not just about the patient, it's about the environment that we have to play into. I call this the psychological shock index. When your heart rate is higher than your patient's heart rate, it's not a good sign. But I'm not joking about that. You do need to figure out ways to sort of manage that. And people tease me because, you know what, I go to the bathroom before resuscitation. I do it for all kinds of reasons. I've got a small bladder. But what I do in that time is I look in the mirror and I do self-talk and I say, I've got this. You know what, if I do what I'm trained to do in managing a pneumonia patient that needs an RSI using a video laryngoscope, it's going to be okay. I might do about 3 cycles of tactical breathing. Right? I find a lot of people talk about this, but when times require it, they don't necessarily do this. So here's our algorithm again. Hopefully, it's we've got a shared mental model. But what's on this is equipment, and you can't just have a list of equipment. So you don't just roll in your Airway card. Right, so what we've got a COVID Airway stock cart, and within it, what we've decided to do is create 2 dump kits. One is the Intubation Dump Kit, and the other one's for the Airway Assistant Dump Kit. So it goes with the person. And what you'll see there is you'll see that things are there in yellow, because I can't fit a Bougie in a baggie. Right? These are things that you're going to have to add, and essentially what you do is lift up that blue cover. and all those add-ins are there for you to bring in. So what you're bringing in is exactly what you need for that procedure. You're going to choose your device. You're going to make sure your device is working, and you're going to ideally have it plugged in there and not depend on battery. And you're going to take in the right blades that are sized for that patient. But even before we go into the room, we have this on the front door, right? It's a stop. It's a remember. Okay, slow down. Do you have your intubation dump kit? Do you have your airway assistant dump kit? Have you talked about your pre-oxygenation strategy? Do you have your pre-dose drugs ready to go that you've drawn up appropriately and labeled? You're not gonna come out looking for towels to position the patient. Do you have to bring in, based on the patient's size, towels to position them, blankets to ramp them, right? We've done our VL device check. Both we're going to take in a MAC blade that size. We're going to take in a hyperangulated blade. Do you have a waveform CO2 setup? A lot of these other rooms that we don't intubate, they don't have the CO2 cartridges, right? What suction capabilities are they in there? What's the location of the ventilator? Do we have 2 IVs done? We've done our briefing. We're going to do our in-room checklist, and we're going to review our algorithm. And then before we go into the room, we have a PPE check and sign off, and we go into the anteroom one by one, and we're either doing it by a buddy system, or again, we have somebody assigned for each shift who's a PPE sign off person, right? So they're checking you before you do your spin 360, make sure you look good and you're all tightened up and have the appropriate PPE before you go in. So the general approach, though, is pretty simple. Right? We're going back to old school double setup RSI. You'll notice on our dump kit that we had a marker. We're marking their necks. We're going to use ketamine at 1.5 milligrams per ketamine, and you can use either rock or sucks at 1.5 milligrams per kilogram. And you know what? If you wait long enough, you can't get more paralyzed than paralyzed. So one is not going to facilitate over the other. They're both good drugs. You just have to wait for them to work. But one thing here, and it broke my heart, but it is the truth, is that awake or sedation only, or certainly awake, is relatively contraindicated in this situation. My anesthesia colleagues were sort of pushing us to sort of keep in there, and I said, okay, you can keep it in there, but it has to be by somebody who's expert in doing it on awake intubation on a COVID-19 patient, and they are hard anesthesiologists to come by. So very infrequent that that's going to happen. But if you do have the question, it's a reasonable one to ask. So what else? We're going to do our primary approach, and this is where we're being a bit specific. We talk about using a MAC blade video laryngoscope in combination with a Bougie. Now, you have to understand that the reason we're using video laryngoscopy is partly because of first pass success rate, but the big reason is that we don't want to be in the face of the patient when we do laryngoscopy. We want to be standing tall and looking at a screen. Right? Our alternative can be a hyperangulated video laryngoscope if you're experienced with tube delivery. So we're not mandating that your primary approach is going to be a MAC VL in combination with a Bougie. If you're very skilled in using a hyperangulated VL, then fire ahead. Your exit strategy, there are several that are there. We're initially going to go with what's called apneic CPAP, but you might tap out. Let's say you've gone in your second attempt with a hyperangulated blade and it hasn't been successful. The tap out go-to is a second generation super glottic, and we're being specific. We're using an EMS iGel because it allows passive oxygenation through it. And ultimately, if you get into an emergency strategy, right, in which you have a CICO scenario, you're doing a Bougie assisted cricothyrotomy. The big modification is that you're not going to ventilate the patient as you enter the cricothyroid membrane. So what you're doing essentially is going down this algorithm, and this is similar algorithm that we've been using for years and years. So it's not much different. Other than the fact that we're suggesting that you consider using a MAC blade with a Bougie. When we decide to go in with whatever dump kit we do, or when we go into the room, we're going to have a pre-oxygenation strategy. We actually have a big plasticized dump kit, and we put out the stuff there, and we roll it in. This is just a quick example of how we transition them, right? So they've been given the drug. We've been pre-oxygenating these patients. I'll back up. We've been pre-oxygenating these patients, and I just posted a video tonight on this. We transition them from a non-rebreather that they might be on to a mask system. And what's different about that mask system is it's a BVM, but it begins with a mask. It's followed by a filter. Then you've got the waveform and tidal CO2. We attach what's called a flexible mount, because when you put all this stuff up, it ends up being somewhat of an unwieldy device. And ideally, you have a pressure manometer and you have a PEEP valve. But what you're doing here is ultimately you're pre-oxygenating by giving them Cpap. And again, you're wearing appropriate PPE, and you're trying to push those numbers up to the ones that Sarah was talking about. We'd like to see a SAT of 90 or above, if possible, before we paralyze them, because we know what will happen once we do paralyze them. So you'll see this here. You'll see them looking up at the timing as we paralyze this patient. And we're now transitioning. We've got our norepinephrine that's hanging. The patient goes down to a 25 to 30 degree heads up position, and I'm doing a thumbs forward VE jaw thrust, not a grip, a jaw thrust. We're rolling in our equipment and proceeding ahead. I just want to finish up with this. So the reason why we're doing Cpap is because it's the best method of pre-oxygenating, and the way to do that is to do probably a minimum of 15 liters through your BVM, and then 5 liters under your BVM with nasal prongs, and your PEEP at 10 to 15. Now those are conservative, and I talk about that in the video on pre-oxygenation that I do, because 15 liters through a BVM when a patient's rendered apneic isn't much flow. Right? Because there's significant decay in that flow. It can be as much as 50% or more, especially when there's a filter on. So what many people are considering is in that immediate pre-oxygenation phase, they will go up to flush rate flow through that BVM with a good mask seal. And yes, you do have some conventional nasal prongs at 5 liters. Those nasal prongs are not there for apneic oxygenation. They are there to provide apneic Cpap. And so if I do this combination, what you're going to see, and you're going to see that I'm not doing a grip, I'm doing an aggressive jaw thrust. So I'm doing this jaw thrust, and I'm not bagging the patient at all. And look at what happens to a lung. Now you're saying, well, this is a lung that doesn't have COVID, but this is a lung that has pulmonary edema. This is a cadaver. So this is a way to continue the oxygenation from the pre-oxygenation phase through that apneic period without actually having to ventilate that patient. And that's really up. I'll show it one more time because it's just so cool. And you'll see more of these videos online. So we've got all kinds of material up on our site. There's these procedural videos on the VE grip, on apneic Cpap, on Macintosh video laryngoscopy, on hyperangulated video laryngoscopy, and an emergency cricothyrotomy. We also have a section here. Well, actually, this is just sort of going back again. Why are we suggesting using Macintosh laryngoscopy as a first go-to in combination with a Bougie? And it comes down to this. Again, the purpose of using video laryngoscopy is so you don't have to be in the patient's face. But the reason to do Macintosh video laryngoscopy is we have pretty good literature here, not level C or level C evidence here. I said level 3 evidence here. What we've got good evidence is that using a Macintosh blade, a disposable Macintosh blade, here the CMAC, in combination with a Bougie, they had a 98% first pass success rate. And they didn't have a 98% first pass success rate because they used a Bougie. They had a 98% first pass success rate because they trained to do it. This was essentially a CMAC study, doing an RSI, using a Bougie routinely, and this is what we should strive for. You can use a hyperangulated approach, as I said, on the first attempt, but you have to be skilled in the way that you do that. And you have to have an appropriately shaped endotracheal tube. A lot of people talking about using a Bougie for hyperangulated blade. A Bougie out of the package is straight and should not be used with a D-blade or a traditional glide scope. So if you are experienced in using a Bougie with a hyperangulated blade, then you can do that. But that's not the first time you want to try that in this patient. You need to be experienced, go to the lab, and make sure you're good at doing that. And as I said, there's full videos on that. All right, that's the way we end. We just don't have these as cards. We have them posted this size in our rooms, from behind and in front of us. The next video I'm going to do is really take us through this algorithm. That's it.
That's great. So Sarah, are you going to jump in?
Yeah, I'm happy to. I'm happy to jump in.
Sure.
So once you have your patient intubated using George's techniques, I just want to give you the first few steps that I would offer in terms of managing that patient. Number one, they need to be sedated with analgesia and something to make them sleepy. This also helps just reduce your metabolic oxygen demand, so it makes it easier to fix hypoxia for these patients. So you want to take those things in the room with you up front so that you have a sedation strategy for these patients. And then I want to just walk you through what I would use as my initial vent settings. So for these patients, I would tend to use a volume control approach. That means you're setting a tidal volume on the ventilator, probably about 6 cc's per kilo. And when you're figuring out what 6 cc's per kilo is, this is based on the patient's predicted body weight. So this is not their actual weight. You need their height and their gender to calculate their predicted body weight. And then you want 6 cc's per kilo of that. And that's what you're setting as your initial tidal volume. You're going to give them some PEEP. We know PEEP helps us with oxygenation problems. So usually 8 to 10 centimeters of water of PEEP. And then you also want to set a rest rate with this. We're going fairly high with that initial rest rate, often in the 20s, say 25 as a starting number. Most of these patients, as we mentioned, were quite tachypnic early on. And last but not least, you need to set your FiO2. So we're starting with a... Yeah. Beautiful. No problem. Okay, so volume control at 6 cc's per kilo, PEEP of between 8 to 10, rest rate of 25, and then an FiO2, start at the max, start at 100, and then you dial it down to achieve that SAT in the mid-90s. And this is the same as you would dial down your FiO2 just on nasal prongs. You turn it up or down right there at the bedside, and you can see the impact on the SAT. So you start at your FiO2 at the top at 100%, turn it down. We prefer FiO2s of 60% or less. So if you can achieve that, great. If you can't, it's okay to keep them a little higher. We are not seeing significant lung toxicity in these patients from hyperoxia. But those are the initial settings you want. If with those settings, you're not getting adequate oxygenation, you can turn up your FiO2. You can turn up your PEEP. Those are your two moves on the ventilator to help you with oxygenation. But I will say we find in these patients early on that they don't really love high PEEPs. They are different from normal ARDS. And in those first few weeks of COVID, we were ventilating all of these people like ARDS, and I think that was the wrong strategy. Early on, they've got high compliance, they've got low elastance, they are not recruitable. The high PEEP doesn't help them. So if you're really running into trouble and sedating them is not enough, you can do a few things on your ventilator, turn up the FiO2. You could increase your tidal volume a little bit. If you start at 6 cc's per kilo, you could go to 7 or 8 cc's per kilo. This is going to help you expand the tidal volume you're delivering, which reduces their dead space fraction a little bit. These patients do have significant dead space fractions. On the metabolic side, you can also paralyze these patients. So keeping your patient paralyzed helps the ventilator match them effectively. They never work against the ventilator when they're paralyzed, but it also reduces their metabolic oxygen demand. And we're finding that paralysis makes a huge difference in how well we're able to oxygenate these patients. Last but not least, you can prone them. Don't prone them by yourself if you've never done it before. It usually does take a team of 5 or 6 people who have been trained in it to successfully prone an intubated person, because there's a really significant risk that they can become disconnected from the vent. So you want to be careful with this and make sure you've done some training on it before you try it. So once you've set those initial settings, you're going in to do a gas about 15 or 20 minutes later. For these COVID patients, when hypoxia is their primary problem, it is nice to have an ABG rather than a VBG, because you get an accurate PaO2. Normally, we don't really care, but for COVID patients specifically, an ABG is helpful. And so if I am going in to intubate one of these people, I take a central line kit and an art line kit in with me. And I do it all that first time when I'm in the room, so I can do all of the procedures they need, and I don't have to change my PPE, and I don't have to stand there in the room waiting for somebody to bring in the gear I need. They're going to need this stuff. Once they're intubated, these people are going to be in the unit for a long stretch. They're going to need lines. So I just take it all in with me at the beginning. So those are basics of the initial vent settings I start with. And George, I'm happy to hear thoughts about that, or Kirsten, happy to take questions about that.
We have a lot of questions coming in, so maybe I'll let George, if he wants to jump in with anything, and then I think we can go to the discussion.
Sorry. No, I don't have anything to add to Sarah. So I'm good for questions.
Okay, great. So I'll just throw them out, and then either one of you can answer them. There's some interesting ones just pertaining to your talk, George. For example, is a jaw thrust done after sedation, because normally this can be painful for patients? And also, George, that there's been some comments from New York doctors that there's a lot of airway edema making a Bougie more difficult than a rigid stylet. And can you comment on this?
Yeah, so I've heard both of those situations. I agree that you're not going to, as you saw in that video of the transition there's 2 of us holding the mask. Sometimes patients will have a strapped-on mask, depending on how they were being treated beforehand. But we'd obviously transition off of that, and then really it's a little bit of a choreographed piece in which as they become unconscious, you are transitioning them to applying a VE grip. I've had it out with both Nick Crimes and Chris Nixon. It's not about the grip, it's about the lift, right? So it's got nothing to do with pushing on the face here. What you have to do is you have to open the airway, and it's most effectively done with this grip that will allow all hands of all sizes manage all patient sizes. So you need to keep an open airway with that, and you're right, you need to be gentle and transition it to the head of the bed as they become unconscious. What was the second one?
Well,
question?
there's just about the use of actually a utility of a Bougie when there's so much airway edema. I understand that it's very difficult even to see the cords in some circumstances, and maybe Sarah, you can also talk about this phenomenon of this incredible secretory mechanism that gets started with COVID, and how it impacts intubation, and that a Bougie might not be an ideal first option.
Well, 2 things. I mean, if your secretions are in the way, the whole purpose of using the Bougie is that you're trying to actually watch a smaller device go in the right hole. So if you've got secretions and you're approaching the glottic inlet with something with a bigger diameter, then I'm not sure if that's going to add any advantage. I've heard some challenges about people talking about Bougie use. But again, from a secretions point of view, you would manage that as you would normally, and you would suction the patient, and then you should be able to see the glottic inlet. The real reason why the Bougie adds value isn't because there's a whole lot of grade 3 views, which that was the classic teaching. It is for the most common, which is a grade 2 view. And what happens is that as the tube approaches the glottic inlet, you lose the view, and this way you can watch it go in. So I'm not sure of the reason why. I'm a real big disbeliever of using a Bougie with a hyperangulated blade unless you either have a steerable Bougie or you have considerable experience in terms of how to bend the Bougie appropriately in that scenario.
And Sarah, sorry, go ahead.
Yeah, the other thing is we are using ketamine, but there's no way that ketamine effect on increased secretions should be occurring at that stage. So it should be easily manageable.
That's a good point. And Sarah, I don't know if you want to comment not just on the secretions, but on the airway edema itself.
Yeah, we have seen these quite edematous airways. Personally, for me, when I'm going in the room, I take a Bougie and I take a Stylet'add tube. So I have both options there with me. I personally go Bougie first because that's my preference. Even when I have a terrible view, if I can feel it going tracheal and bouncing off the anterior tracheal rings, I can get tactile confirmation that I'm in the right spot. So that is my preference. But I do think people want to go with what they are best at. Optimizing first pass success is critical here. So practicing, as George said, is a key component of this to make sure we are upskilling so that whatever you do first is your best possible go.
And I guess on that note, there's also some questions about using direct and why we are not doing that. So perhaps you could just touch on that, please.
Sure, and that goes back to the experience in Toronto, the real reason why we're using video laryngoscopy isn't necessarily for first pass success rate, although I think it is supported by papers like the driver paper. The real reason is that so you're not in the patient's face. This is an aerosol generating procedure. You've rendered them apneic as part of an RSI. And you've got the appropriate PPE on, but you want to be standing tall and looking at the screen. Now I've got to again watch our videos on video laryngoscopy. It's not about looking at the screen. People will be looking at the screen and having trouble, and it's because their laryngoscope's underneath the tongue. So you always have to, whatever you place in the mouth, you have to look in the mouth, right? And then you transfer to the screen, and then you grab your Bougie and you look in the mouth, but you're not looking down, right in there. You're standing tall, and you're using a big screen, such as you have with a Stort CMAC or you have with a glide scope. So the real reason is to protect you and protect the people around, and we think it does give first pass success, higher
Great.
First pass success.
And also there was a question about using nasal prongs after apneic Cpap to avoid flow. I guess, is it important to remove or turn off nasal prongs after apneic Cpap to avoid flow through nasal prongs during intubation? I understand we're not using nasal prongs during intubation in these patients, but perhaps you can answer that question.
So we are using nasal prongs, and we're again, the purpose of our using nasal prongs is not provide apneic oxygenation. These patients aren't going to benefit, I don't think, from nasal prongs in terms of apneic oxygenation. The reason why we're using nasal prongs is to help generate the Cpap, to be able to generate the PEEP that allows you to most effectively pre-oxygenate. These patients are apnea intolerant. Right? That your sats are going to be 90, 92. They are going to fall precipitously. One of the most important things that you have to do in the room is tell your team they're going to lose their sats. And that's even more critical if you fail first attempt and you're trying to re-oxygenate that patient, because you're only going to give that reoxygenation period time probably about a minute, and the sats will probably have not come back up. And the only way you're going to know that you're doing that well is by doing some looking at waveform capnography, which is another piece. So two things. I do use nasal prongs under the BVM, but the question that you asked is, do you turn flows off? There's two thoughts about that. One thought is that the amount of flow that's going to come through a BVM, even if you had it at flush, so let's say it's at 15 liters, we know that you have flow decay of at least 50%, plus you have a filter on. It's probably negligible, but it makes people feel comfortable, and so people are turning off their flows. Whether you turn down your 5 liters of nasal prong flow is a little bit more debatable. What people are often saying, okay, just be consistent, turn it all off, okay? But what you have to remember is to turn it back on, right? If you fail, you need to turn it back on. So you're not just done. Hopefully we are done, right? So we take off our BVM, and we're in 98% first pass success rate, and we don't have to worry. We've turned off our flows, but when we hook them up to oxygen again with our BVM, we need to turn our flows back on. So if you're a believer in turning them off, remember to turn them on.
Great.
And Kirsten, can I just add about how fast they desaturate? George is totally correct. They desaturate really fast. So I have two thoughts about this. One is, I do not lie these patients down until the last possible moment. I keep them sitting up, which optimizes their respiratory mechanics and their matching. I induce them and I paralyze them sitting up. And then just before I'm going to intubate them, I lie them flat and do it then, because it helps preserve their oxygenation a little bit. But my other tip for this is, please make sure you have everything in the room that you want before you induce them and paralyze them. Have the tube in your hand, or the Bougie or the Stylet'add. Be able to see your VL screen. Have everything you need for afterwards, a syringe to blow up the cuff, your end-tidal CO2 monitor, whatever you need. And in your room, run that list with your team so everybody's on the same page before you push the drugs. Because you don't want any procedural delay here that you can avoid. They will desaturate fast.
Great.
And nobody count down the numbers. You're not allowed in the room if you do.
And don't turn on the beep, so it's going beep, 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 beep.
Okay. Sarah, perhaps you can answer this question. Can you speak about inspiration versus expiration ratios, the ratio of time? It's one question about ventilators, if I'm not mistaken.
Yeah, so it's about I to E ratios on the vents. So I'd say you could use a standard I to E ratio, say of 1 to 3. These patients don't have a prolonged expiratory time. If you're really struggling with their hypoxia, you could narrow that down to a 1 to 2. I think if you're going to talk about doing sort of 1-to-1 or inverse ratio ventilation, then you probably want a really experienced RT with you. But they don't need long I to E ratios.
And what are ideal peak pressures, and should they be maintained or avoided?
Yeah, so I like keeping plateaus less than 30, say. And this is usually not a problem. They aren't taking huge pressures to ventilate them. They're just hypoxic.
Okay, great. So there's some questions about using a hood. Are you using that, Dr. Povich, in your site? Are you using these acrylic kind of hoods or other contraptions?
Are you talking about hood over my head or a hood over the patient?
Well, I think for both, that maybe you could address both.
Well, I mean, I'm wearing what you saw in terms of our PPE. Again, this is beyond my expertise, but it's an important piece that the person doing the most dangerous procedure that's going to be done needs to be comfortable with what PPE they're wearing. And again, that comfort has to meet a minimum standard from an infection control point of view, but it has to meet a minimum standard from a point of view comfortable doing that procedure, right? Again, whether it's fogging, peripheral vision, glaring, etc. So we do wear headgear. I'm thinking you're asking about the New England Journal contraption hood for laryngoscopy and intubation. Is that clear? Is that what they're being asked also, or?
Yeah, I mean, well, perhaps you could touch on that. It was just a general question about using a hood, so perhaps they are referring to that. Yes.
So again, I said level 3. I'm talking about class C. If there was a D for class of evidence, I would put that there.
Mm-hmm.
So the messaging is this: you've got a pneumonia patient, right? You're an emerge doc who's done RSIs. You're familiar with the video laryngoscope. You're working with the team that you used to work in, and you've got this PPE on. So you want to keep things similar as possible to what you do. So having a plexiglass get up that you don't know how you enter it and how the suction's going to bump and stuff. Maybe it works if you've got a team that's been doing it and they've done 100 of these, right? But it's like having a checklist or a visual aid. It is completely useless if you bring it to the patient. So there may be a role, but I was pretty disappointed to see that in the New England Journal. As many of us were, because it carries a lot of weight because of where it was published. But the principle is that there's more things in common with this procedure than there are differences. And as soon as you start adding on differences, you're going to create problems and create error. If it was just about wearing a hat, yeah, I'd wear a hat.
What are the challenges that you foresee with the idea of 3D printing glide scopes, scats, blades, and how could these be overcome?
So that one was sent before, and I wasn't really sure of the question whether you're 3D printing glide scope blades, what the context was.
Yeah, I guess, I mean, perhaps that's just a thought if we're short on the blades in terms of not having enough resources. But I guess you haven't heard of any of that kind of activity. I certainly haven't in Quebec, at least.
So I get a call from Rich Leviton when he got to Bellevue, and it's funny. He called me from the resuscitation room, and he's we've known each other a long time, but he's one of these people who doesn't introduce himself. He just launches into a discussion, and he just saying, I just intubated this patient, described the patient, and he was going on and stuff, and we used this apneic Cpap, worked great. And then he said, oh, I got to go. He hung up the phone, and then I said, okay, all right, call back. I said, the reason why I wanted to call is, can we wash PEEP valves? Can you check into me whether we can wash PEEP valves, because they're out of PEEP valves? So you do have to think, when resources get strapped, you're taking all these, these disposable blades, and they are on back order for some of them. Whether there is something safe to do. What I told him is I don't think anybody's going to sign off on that in the third world, in the first world. But it is something that we do have to sort of think about in places where they don't have those resources. So I don't know if that was addressing that question, but it does feel kind of terrible taking all these plastic devices and throwing them. We actually throw them into a special bin, and we'll deal with them later. They go to our sim lab. But
it's definitely a problem that we need to consider. I just have a couple of others. And so, Sarah, perhaps this is for you. People are asking about chest physio, moving and probing. You talked about allowing the patient to move themselves, but would you advise for PT or whatever service to come in and do chest physio?
Like for a non-intubated patient? No, certainly not. Not even truthfully for the intubated patients. We are not doing routine chest physio on these people. We're proning them instead.
Great. And how do you, there's an interesting question actually about transferring patients tips or tricks on transporting a patient, whether from the ER to ICU or from a community rural site to another hospital ICU.
Tips or tricks. Okay. Certainly if I'm transporting them from a rural place, so all of this depends on the duration of your transport, but you want to certainly be sure you have a safe airway for your transport, you have adequate IV access for your transport, and you have a backup plan for when things are going to go awry, whether that's, pressors available, a physician available, a base hospital physician, something like that. Obviously, these people are transported with significant PPE. And that can become problematic. So if you've been in the room and are potentially contaminated, ideally, you have a clean team in PPE outside the room, and the contaminated team from inside passes the patient out to the clean team, who then does the rest of the transport. Because you run the risk of contaminating the rest of your hospital or your elevator or your ambulance, whatever it was. So there are certainly risks there, and lots of Virox wipes for after the transport's done to clean everything you touched and spray down your whole ambulance. But yeah, apart from that, just our normal safety checks for anybody who was getting in an ambulance, I would apply.
We've done a lot. The biggest risk is transfer of care. So the transfer of care incoming of pre-hospital to the ED and then outgoing to ICU or to a COVID unit. The challenges we have that get posed, and they're difficult questions. So you've got somebody at a level 3 hospital that now has an intubated patient, and they've got a 2-hour transport time. And the scope of practice of the medics there, doesn't allow them to keep the patient paralyzed and necessarily give sedation. And then that hospital can't send the resources away from their place. And me as medical director, one of the things we hate about spring is fog, and we can't come and get these patients. So how do you manage these? And we've come up with some protocols in doing that. You definitely, what we're suggesting, these patients, the worst risk is for these patients to be extubated and spontaneously breathing, and them being faced with having to intubate in the back of a truck, right? So we want to have a secure tube. You want to have that patient paralyzed before. And then have the appropriate sedation, and we're going to start them on their neurepi, whatever they need, and we're changing scope of practice to allow them to continue those infusions en route, and we're looking at changing scope of practice to allow them to use drugs that they weren't allowed. And what we've done is we've upgraded the medical control that they have. So if you're transporting a patient from a small hospital to another one, and the initial request came in from Life Flight, we as medical control physicians will stay online for medical control for that. It won't revert to the ground transport, so that we can help them perhaps with some out of scope situations. So difficult times calling for difficult situations to make pragmatic input.
That's great. And I think the last kind of question, and this also comes from my end. I've had a couple of cardiac arrests when, unfortunately, things haven't been as smooth as we had hoped. And there's a question that's similar to mine, which says for a code blue on the floor when there's a delay in donning PPE. So there's a cardiac arrest, and it just takes a little bit for the team to get in there. Would inserting an LMA be aerosol generating in order to be able to ventilate? Could that be an acceptable first option if everything wasn't there, the glide scope and so forth, to secure the airway and then to start CPR as well? And could you comment on there's been some I guess changes in protocols in some places around doing chest compressions without or before securing the airway?
Sure. So I can tell you our approach. Certainly it is vital that all of the healthcare workers put the appropriate PPE on. Yes, that does mean it takes longer to get in the room. Yes, that does mean the patient may get delayed CPR or airway management. And this is one of the unfortunate realities of ACLS in the time of COVID. When we enter the room and we're starting CPR, we will put a non-rebreather mask with a filter on it, like a Hyox or a Tavish, on the patient's face while CPR is started until airway equipment is ready and an intubator is ready. As soon as we have airway equipment available, we stop CPR, we pause compressions for intubation, and the airway is the priority. And we don't go back to CPR until the airway is confirmed and closed on a circuit with a viral filter on it. So we have modified our typical approach to ACLS in order to keep healthcare workers safe.
Mm-hmm.
Yeah, so I agree. I mean, there's several approaches out there. That's the one that we're using to. I think that the key thing is that you approach the patient. If you are going to use a supraglottic device, it's a supraglottic device with a filter then, right? And then it depends. So, for example, if you use the EMS eye gels, they actually have a passive oxygenation port. So you have the filter on, and you can use that passive oxygenation port, but you're going to passively oxygenate as a piece. There's one other group that I think it's important to differentiate with. So a lot of these aren't coming in. So if they're not transporting non-ROSC patients, many systems. And even, I guess it depends on whether you have an ECMO programs, but I imagine most ECMO programs right now or many are perhaps on hold. But the situation you have to be aware of this is that we knew that for critical care intubations that there was about a 3% rate of post-intubation cardiac arrest. Right, and again, this is in part for many reasons. It's multi-system, but they're apnea intolerant. So you can expect with these patients that their SATs plummet, that we're going to have a higher incidence of cardiac arrest. The difference is that these patients have a high return to ROSC. Right, because they're going into cardiac arrest because we're giving them positive pressure ventilation. Right, we're giving them drugs that affect their blood pressure, and it's a combination of the hypoxemia, the positive pressure ventilation, and the medications. So that if you do the appropriate resuscitation, they will come back, and you would do what you would do normally. So these are almost always are PEA arrests, right? So they can be hypoxemic arrests, and it doesn't mean that you're going to, obviously, as part of this, you're going to check the rhythm, and if it says analyze, it says give shock, we're going to give shock. But the post-intubation cardiac arrest has a high ROSC rate by doing the things that you would do. And they've got a cuffed endotracheal tube below the cords, although one of the reasons why they might be in cardiac arrest is not in the right place. So no trace, wrong place.
Right. Well, super helpful and very interesting discussion. We have about 50 more questions, but we've almost run out of time. So what we'll do on our end is Patrick, who's our super medical student, will organize all of those, and we'll get them out to our speakers. Hopefully we'll be able to finish answering some of those for you if there's anything that we haven't addressed today. And I apologize that we couldn't get to them all. I guess I'll just turn it over to our two speakers to see if they have any key take home or pearls that they want to impart. before we finish with our session for this evening. And again, apologies to our colleagues who are celebrating Passover and couldn't be with us, but I do hope that you'll be able to enjoy the recording at your leisure. So Sarah, did you have anything else to say? And then George.
I would just say that I hope everybody is staying well, that this is a stressful time. We're focused a lot on airway and resuscitation and critical care. These are stressful cases at the best of times. And this is my other hat, this is my wellness hat coming to the fore here, but it's a good time to get really explicit about how you will take care of yourself, because we know that providers who are calm and focused do better. You're more effective at resuscitation. But that is a real skill in this era of anxiety and stress. So stay safe and healthy out there. And I'll turn it over to George for the last word.
Thanks. Repeating the same thing Sarah did. I was, I was speed talking, and that's what I tend to do at times. But again, there's a ton of resources on our website. So again, video support material that again is open access, and you should spend some time there. aimairway.ca. The last thing, and I'm going to maybe trigger Jeff to maybe play this video because it speaks to what Sarah just said, and I'm not joking. I watch this video every night, and what you have to do is you have to get through the first 30 seconds or 45 seconds of it. But it's to me anyway an amazing video. And Jeff, that's your that's you. Thank you.
Are you scared yet? They say this thing, it kills your immune system, attacks your lungs, makes it hard to breathe, and it's spreading like wildfire, causing havoc. Your friends and family are gonna get it, if they don't already have it. It's tragic, I tell you, madness. Scientists say old people get it worse, but most get it eventually. They say this is new, but no. This has been around for centuries. Look at history, it's just a different name, a different strain. And now there's no way to contain it. It infects the rich, poor, young, old, the unknown, the famous. It's dangerous. Everyone's on edge, locked inside of their homes nervously. Borders are closed, countries declare state of emergencies. Grocery stores are empty, nobody's praying in church. The world has gone to crap. No wonder toilet paper sold out first. The stock market crashed, thousands laid off work. Hand sanitizer is going for $1 million a squirt. You better not sneeze, cause no one's gonna say God bless you. They might even arrest you. I don't mean to stress you, but washing your hands obsessively in the restroom will not protect you. Friends, I'm not talking about coronavirus. Now this is a virus even more deadly. The F virus. You've seen it. It spreads every minute like an epidemic. It lives on surfaces, most commonly remote controls, TV screens, cellular phones. It makes you desperate. Doctors say every time you scroll down your feed, you get reinfected. It invades the brain, and when it mutates, it turns into hatred and blame. China did it, no Italy did, no Iran, no Spain. Oh, I didn't make it clear? The F virus, ladies and gentlemen, is fear. But don't be afraid. Despite what you hear or see on your TV, there is good news during this tragedy. To fight loneliness, people are performing concerts on their balconies. The UAE sent aid to Iran. Japan donated supplies to China for free. Written on them was a poem that said, "We are waves from the same sea." Listen to me, like every tragedy, we can let this destroy us, or we can use it to our benefit and repair relationships with our sisters and brothers, wipe away silly grudges, because when it's all said and done, all we ever really had in this world was each other. So yes, let's flatten the curve and expand our hearts. Let's social distance, boost our immune systems, be mindful of where we put our hands, but also where we put our attention. Be alert, not fearful, because the F virus is a pandemic easily transmitted. If you do contract it or exhibit symptoms, we recommend immediately dialing the hotline of a level-headed friend. If you are exposed through your TV, change the dang station. Decontaminate yourself through dance, laughter, and meditation. 2020 has been morbid. From Kobe to COVID, may we use these tragic moments to finally wake up to what's important. Right now, tell someone that you care for them. Yes, right now, tell them that you cherish them. If they are not in the same room, ring them up and tell them you will always be there for them. Because together is how we will rise above. The only vaccine for this F virus and every other virus is love.
So thank you to everyone who joined us tonight. It was a very impactful evening with a lot of great information. And so I hope you'll join us next week. And take care of yourselves. What you do is important, so keep on doing it. Good night.